great to have you here this morning. We're going to leave the doors and hope a few more people will join us. My name is Michael Nyenhuis. I'm the president and CEO of Americares. Americares is a global relief and development organization focused in the area of health. We believe health is the fundamental requirement for development. With good health, kids can learn. With good health, parents can provide for their families. And with good health, neighbors can work together to build better communities. And poor health puts all of that in jeopardy. That's why we focus on ongoing health programs across the country, the U.S., and across the world every year. We respond to emergencies. We deliver medical aid into as many as 90 countries every year doing that. We also respond to outbreaks and epidemics. Currently, our clinic in a rural area of El Salvador is responding to the Zika crisis by doing prevention, education, and training in the rural communities that it serves. We've been very active in outbreaks like Ebola. We were heavily involved in West Africa, all 3 countries, delivering critical personal protective equipment and other materials, doing training for local medical staff and infection prevention and control, and staffing and managing one of the Ebola treatment units that was set up in Liberia. In Liberia, I had an interesting experience that ties to this idea that health affects all of development. I was invited by President Johnson Sirleaf to sit in on one of her weekly Ebola task force meetings. And this was fascinating just to be there sitting on a chair on the wall and watching her manage the Ebola crisis around this big conference table. And around that table was, not surprisingly, people from the Ministry of Health. There were CDC representatives there and other health-focused people. That made sense. They were fighting a health epidemic. But also at that table was the Minister of Education and the Minister of Finance and other ministers from the government. And the Education Minister was talking about how to reopen schools. In fact, kids' learning was jeopardized by a health epidemic. The Finance Minister was talking about the impact on the economy and what was happening there. A health epidemic impacting the finances and the financial health of a country. So when we say that health impacts the rest of development, it does, and epidemics are an important part of that to put things at risk. So today we're going to talk about epidemics. We're going to talk about the threat that they pose to development, and we're going to talk about some of the solutions. And we have with us just a tremendous panel that's going to talk about their own experience and give us their perspective on it. We're going to begin with some opening remarks from Dr. Tom Frieden from the CDC, and then he'll join a panel that's going to be moderated by Dr. Richard Besser of ABC News. I'm going to introduce both of them and then ask Dr. Frieden to come forward and deliver his presentation. He'll join the panel then, and Dr. Besser will come up to lead the panel for us. Dr. Frieden is going to deliver the opening remarks. He's the director, as you know, of the Centers for Disease Control and Prevention, a position he's held since 2009. He's obviously one of the world's foremost thinkers, voices, and practitioners in health of all types, but obviously epidemics and outbreaks as well. At the CDC, Dr. Frieden has intensified the agency's 24/7 readiness and response to disease outbreaks and other health threats, as well as addressing ongoing threats to public health from smoking, obesity, foodborne illness, and more. He was previously Commissioner of Health Department here in New York City for 7 years, and in the early 1990s, he led New York City's program that controlled tuberculosis and reduced multi-drug resistant cases by 80%. He also worked in India on a TB program that saved nearly 3 million lives. Dr. Besser, who's going to moderate our panel today, is a pediatrician and infectious disease specialist. He is ABC News' chief health and medical editor since 2009. He provides medical analysis and reports for all of ABC News programs and platforms. His Facebook chats and weekly health Twitter chat reach millions. Of special interest here today, Dr. Besser reported on the Ebola crisis in 2014, entering Ebola treatment wards in Liberia. Previously, Dr. Besser spent 13 years at the CDC, where he served as director of the Coordinating Office for Terrorism Preparedness and Emergency Response, and served as acting director of the CDC from January to June of 2009. As you can see, we're starting off with terrific expertise to lead us, and Dr. Besser will later introduce the panel. who you'll see is equally capable of representing this topic. But let's begin with Dr. Frieden, please. Let's give him a hand, please.
Thanks very much, Michael, and thank you for arranging this. I'd like to go through just a few slides to set the stage here for where we are. Do we have slides? Right. It's very important that we recognize that health affects far more than the health sphere. And as Michael indicated from Liberia, you saw that both the impact of Ebola and the response to Ebola require the entire community. Next slide. Can I advance these from here? Or no? No, okay. Next. Now I can advance these from here, good. There is a paradox that we have. Currently, the world is safer than we've ever been. We have better technologies, we have better coordination, better communication, we have new tools, new vaccines, new antibiotics, so we're safer than ever. But at exactly the same time, we're also at greater risk than we've ever been before because of those same criteria, because of those same characteristics, that the world is more tightly interconnected, that there are new technologies that can be used for either good or ill, that there are an increasing number of drug-resistant bacteria. So this is the paradox that we're living through. And the fact is, a health threat anywhere is potentially a health threat everywhere. We're seeing this in Florida today, where we have Zika spreading in Miami Beach. A single traveler with a single trip can result in the spread of a pathogen from any part of the world to essentially any other part of the world. And the world has lived through some horrific epidemics in the past, most notably the 1918-1919 global influenza pandemic. And it's worth spending a moment to remember just how devastating this was. Between 50 and 100 million people killed. That was between 3 and 5% of all people in the world. It's really almost inconceivable, but that's what happened. Life expectancy temporarily declined by about 12 years. And what you see here is life expectancy at birth, and that dramatic drop is the influenza pandemic. A pandemic large enough to change life expectancy. Sound familiar? That's what AIDS has done in Africa. AIDS, however, has killed fewer people in 24 years than in 24 weeks from influenza. There was huge economic disruption. An enormous proportion of the world's GDP basically disappeared in that period. Most of those who died were healthy young adults, and it wasn't just influenza, and this was also a lesson with Ebola. It's quite likely that more people died because of Ebola than from Ebola in West Africa. Ebola shut healthcare systems. Vaccinations stopped. TB treatment stopped. HIV treatment stopped. Cesarean sections stopped. Routine deliveries in hospitals stopped. Even in the United States, even in this country, we had 2 patients come in who had traveled to West Africa and had malaria, proven malaria. And there was an unwillingness to go in and provide them with treatment, and they almost died because of the difficulty of providing health care in the context of a scary pandemic. Despite this, most of the world is still unprepared. This is self-certification. The world agreed that they'd be ready to find, stop, and prevent health threats by 2012. We were at 16% by 2012. We're at less than 33% by 2014. We'll know later this year how we are in this year. So we're not doing that well in terms of preparing the world for the kind of pandemic that we're likely to face. It would be a terrible mistake not to look back and say, what did we learn from Ebola? There were a few really important lessons. First is that speed is of the essence. We documented with Ebola that cases were doubling every 3 weeks, and we needed to make progress in hours and days, not in weeks and months. When there's an epidemic, when there's an outbreak, the sooner you get there, the bigger difference you can make. The sooner you get there, the more you can curtail the problem. We've made the analogy, because there are now efforts to establish something like a public health rapid response mechanism in the United States, to FEMA, the Federal Emergency Management Administration. But there is actually something that's even stronger in terms of the case for epidemics. With an earthquake or a flood or a tornado, you go in afterwards and do critically important relief work. With an epidemic, you can do the equivalent of stopping an earthquake if you get there fast enough in many cases. Every country has to be prepared. A blind spot anywhere is a risk everywhere. West Africa has some of the least developed health systems in the world. This is one of the reasons that the epidemic got so far out of control. So we need to ensure that we're strengthening the entire world's capacity to find a threat when it first emerges, respond to it rapidly, and prevent it wherever possible. But when a country's capacities are overwhelmed, we also have to be able to surge in as a world very rapidly. We have to move from a world where pre-Ebola there was non-accountability. Countries could self-certify whether they were ready, and there was non-assistance. It didn't matter what they said because nobody helped. To a world where there's true accountability. We know what's happening in countries and true assistance. We're helping countries to improve their capacities. Now, lest we think that we're out of the woods, this is a rogues gallery of some of the most deadly threats. We've talked about influenza, avian, or other. We continue to track this. This remains an ever-present threat that there could be a new pandemic. Each year, in a good year, flu kills thousands of people in the U.S., and many more around the world. Hemorrhagic fevers. We've talked about Ebola, got a lot of press. There are tick-borne hemorrhagic fevers. There was a case in Spain just recently, spread to healthcare workers. Can you imagine if instead of Lyme disease in this country, you worried about getting Ebola from a tick bite? But that's possible. Drug-resistant bacteria, carbapenem-resistant Enterobacteriaceae. This is really the nightmare bacteria. This is a bacteria that has a transposable element, a plasmid, that spreads from species to species and encodes for resistance to all of our best antibiotics, first, second, and third generation cephalosporins. It is spreading in our healthcare system, and it threatens to bring us back to a pre-antibiotic world or into a post-antibiotic world. And sadly, anthrax or other bioterror attacks are ever present, either intentionally or unintentionally, as we create more dangerous organisms in the laboratory with more resistance, more spreadability, more virulence. We have the risk that they will be released. And this is just a few of the risks. There are many more risks. Most likely we won't know. We can't predict what the next one will be. No one would have predicted that Zika would cause birth defects. No one. And yet that's what we're dealing with now. What we hope to see is a safer world through global health protection, where we focus on measurable, accountable outcomes in prevention, detection, and response. Prevention, everything from laboratory biosafety to immunization, which is crucially important, surveillance for zoonotic diseases in humans and antimicrobial resistance, detection, so we have early warning systems, surveillance, laboratories that can actually determine what's happening, information systems so we can see when there are discrepancies or increases, and disease detectives and other public health staff who can go out there and investigate and see what's happening and respond effectively through emergency operations centers, linking public health and other parts of society. We have three critical needs: money, whether it's dollars, pounds, yen, euros. U.S. is providing about $2 billion over 5 years for the global health security agenda, but that's less than half of the total need. And there's a need for all countries to contribute. So low-income countries need to do what they can within their resources. Middle-income countries need to fully meet their own needs and have South-South collaboration. And OECD countries need to contribute both because it's the right thing to do and for their own protection. We need trained and supported staff, particularly in low and middle income countries. We need to grow the field of public health. We need to have more people who are able to find when there's a problem and respond effectively. We're not going to fix this by having some great global system that goes in and tracks what's going on in countries. We're going to fix it by improving what happens day in and day out in countries around the world that are faced with threats. In Brazil, they had trained epidemiologists. They saw something unusual happen. They did a rapid assessment, and they sounded the alarm early. Otherwise, we would be months further behind. However, if we had had better information, we might have found out about Zika years earlier. And accountability, crucially important. Joint external evaluations are a critical component of the global health security agenda. And this is my last slide. I'm going to stop here, but I do want to emphasize how crucially important this is. You see a lot of white on this map. That will change to red, yellow, or green over the coming year. More than 50 countries will go through joint external evaluations. They will rigorously look at whether countries are adhering to what they're committed to in the WHO international health regulations. And we'll look objectively. Are they able to find, stop, and prevent health threats? The table you see here are a dozen countries that have gone through this in various ways, and you see different aspects of prevention, detection, response. Overall, you see a score, you see a color, it's accountable. The system isn't perfect. It's not yet exactly apples to apples between countries, but Peter's going to make sure that happens. And all of us need to ensure that it's a commitment. It's a commitment to both open ourselves up, and we in the US went through the evaluation. We actually, quite frankly, found it more useful than we thought we would. It was helpful. It had us connect with other parts of the US government. It identified weaknesses and areas we needed to strengthen. You'll see in the US we're not at 100%. We're at 85% for response and 87% overall. So there were areas that we had to improve. So it's a commitment of every country to transparency, but also our commitment to assistance, a commitment to saying, if a country is opening itself up and saying, we lack this capacity, then that opens the door for a donor, a private sector organization, a multilateral organization, or the country itself saying, we're going to work to fix that gap, to close that gap, and in another 1, 2, 3, 4 years, another independent assessment will come, and there will be an assurance that there will be accountability as to whether the investment in that important aspect of preparedness has been successful or not. And that, I think, is the way we make progress in making the world safer and more secure from infectious disease threats. Thank you very much.
Well, thank you all for coming this morning for what I think should be a very interesting discussion. Tom, I want to thank you for setting the stage. I want to introduce the panelists who are here. Tom, you just were introduced, so I'll skip that, and my introductions will be short. Dr. Frieden has to leave at 10, so we are going to stop promptly at 10, and then at that point I'll invite Mike back up for a closeout. But with us is Dr. Seth Berkeley. He is the CEO of Gavi, the Vaccine Alliance. And before coming to Gavi, Seth founded and led the International AIDS Vaccine Initiative. He worked for 15 years on the development of vaccines against HIV. He's been listed by Time magazine as one of the 100 most influential people in the world, and by Wired magazine, a higher measure, according to my children, as one of the Wired 25, a salute to mavericks, dreamers, inventors, and leaders. Next to Seth is Susan Silbermann. She is the president and general manager of Pfizer Vaccines. She has the responsibility for commercial development of a wide portfolio of preventative and therapeutic vaccines. She's been with Pfizer around the globe for more than 25 years. And next to Susan is Dr. Peter Salama. He is the executive director of the newly formed Health Emergencies Program at the World Health Organization. He was formerly with the UNICEF, he was the UNICEF regional director for the Middle East and Northern Africa, and global emergency coordinator for the crises in Syria, Iraq, and Yemen. He's worked in public health for more than 20 years and has published widely in a number of areas in public health. So I want to pick up on some of the themes that Tom raised, and while I'll address questions to each of you, encourage you all to chime in as you feel comfortable. And Pete, I want to start with you. You're in a new position. Tom talked about lessons learned from Ebola, and I want to just challenge that theme, because they're not learned until changes are made. And I wanted to see if you could talk a little bit about what WHO learned from the Ebola response and what it is that the organization may be trying to do differently, and how that may relate, if it does, to the response to Zika.
Thanks so much, Mitch. Can you hear me? Yeah. takes coordination and leadership, and it takes the incentives to be right for countries to report and to really want a response. And that last point is critical because in the system at the moment, there aren't a lot of real incentives for countries to want to report an outbreak. In fact, there are a lot of powerful disincentives for countries to report, including many other countries slapping on trade or travel bans on those countries. So one of the issues that Tom spoke about, which is really important, is to match that transparency and incentivize it with a partnership for a response. So when countries see that they're transparently reporting, but not only do they get the bad news in the media, but they get actually a coherent global response to support them, then they're much more likely to be transparent in that response. So that's one critical element that definitely the JEE, the Joint External Evaluations, which is a centerpiece of the new program at WHO, will assist on.
And are there any changes in terms of WHO response to Zika that have that are a result of things that we're seeing with previous responses?
Yeah, I think both in Zika and yellow fever, there's a real commitment for speed. There's a real commitment to work with a number of partners. In Zika, there's more than 50. In yellow fever, there's a huge number. And there's a real commitment also to work across private and public sectors. In yellow fever response in Angola and DRC, we've seen a real push from the private sector to help us access the vaccines required to stop that yellow fever outbreak in Angola and DRC.
You know, Seth, in the media here in the U.S. anyway, we hear a lot about Zika. We hear very little, if anything, about yellow fever. Just briefly, what's going on with yellow fever, and is it the kind of epidemic that poses a threat outside of the region of Africa where it's occurring?
Thank you, Richard. And by the way, I thought your presentation was great and hit right to the points. And the answer is absolutely. So first of all, you know, what we have to think about, you've seen the spread of Zika. You could watch that map, and it's gone now to, I think it's 60-odd countries. And of course, it is transmitted by a mosquito that also transmits a bunch of other diseases, including yellow fever, including dengue, including chikungunya. You know, and so we have the problem of, you know, with that vector present everywhere, it could spread. Yellow fever traditionally has been a disease spread from monkeys to people. It's been around for a long time. I used to work for the Rockefeller Foundation. It got a Nobel Prize in 1936 for making a vaccine. This vaccine protects for a lifetime, so it should be easy to control it. Well, what's happened is, right now, pretty good control in Latin America. It, by the way, has been in the U.S. as high as Philadelphia. George Washington took his cabinet out of Philadelphia. 10% of the population died when he was president because of it, so it can be there. Now, what's happened with this spread is that there was not wide use of vaccine. There wasn't routine use, and there hadn't been any campaigns in Angola, and frankly, the systems, as Tom talked about, weren't strong, so it took a long time to get a diagnosis and then to respond. Now, the scary thing is 12 people from China went to China with the infection. Luckily, it didn't spread there, but there are 2 billion people potentially at risk given the distribution of the vector. So, as Tom showed in that map, you know, you can have dinner in Nairobi, breakfast in London, and lunch in New York, and that is, you know, within the incubation period. And if we don't catch these, we can see exactly what happened with Zika with these other diseases.
And why was it, given that it was a known threat, why wasn't the routine vaccination something taking place?
Well, I mean, 2 points I want to say on that. People probably have little yellow cards. You know about these cards you're supposed to have. The first index cases in Angola had cards. And so what happened was they said, well, this can't be yellow fever. The vaccine's so effective. So they started chasing other diseases. Turns out they were fake vaccine cards. And so, you know, we have to really be careful. So in terms of routine use, this has to do with the complacency. Now, traditionally, it's been more a disease of West Africa, and so that's the place that we've had wide distribution of vaccines. But as Peter said, we're discussing now with WHO whether we should change, you know, kind of our paradigm and try to vaccinate now much more broadly, because at the end, it's the routine vaccine that matters. It's getting prevention. Yes, we have to have response in emergencies, but I'd rather prevent the disease and have no emergencies than be chasing it all the time, and that's the strategy we'd like to go to.
Susan, so much of the work that you've done has been around vaccines for routine use, for pneumococcal disease and for meningitis, for for problems that are existing in countries all of the time. What role does Big Pharma have in terms of being out ahead of emerging diseases, things like Zika and Ebola, and having vaccines in the ready should they arise? Is that a responsibility for Big Pharma?
I think we believe, Richard, it's clearly a part of that accountability that Tom mentioned. You know, part of the role of the industry that's involved in vaccine invention and then development and eventually production is to make sure that we can stand together with all partners like these on the stage and many others to be at the forefront of getting these diseases before they become epidemics. So vaccines, I think the statistic is after clean water, it's been the greatest contribution to public health the world has ever known. Millions and millions and millions of diseases have been prevented because of routine use of vaccines. And so what we're seeing now is we need to take some of that knowledge about routine vaccination and turn it into this preparedness. And so Pfizer, among many of my industry partners, are a part of a new joint effort that's just been formed called the Coalition for Epidemic Preparedness and Innovation. And our goal as a part of a multilateral organization that's just being set up is to really be there at the table as many of the scientists represented by Tom and by Peter are talking about, one, predicting what's the next Zika. Is it chikungunya? Is it tick-borne encephalitis? Is it something that I don't even know the name of today? Once we have the scientists to predict what it could be, then it's our job as industry, together with academic and NGO partners, to innovate around what's it going to take to get a vaccine ready. Because the epidemic becomes a pandemic, unfortunately, sometimes in the, well, maybe not the blink of an eye, but the movement of an airplane, right? Vaccines take years, sometimes decades, and many, many failures before we succeed. And so we put together in this coalition the best minds to figure out what that vaccine needs to look like, bring it up to a development point where it can be ready for emergency use, and then complete the regulatory process to have it approved eventually for routine use. You know, I think it's going to be interesting to see as the first Ebola vaccines make it through the approval process, whether they're going to be recommended for routine use for healthcare workers, whether they're going to be recommended for use in the communities where Ebola already was a devastating, life-changing disaster, or whether we're going to sit back and see people say, well, I'm not going there, it's not a big deal. I think part of our role, and the role of a panel like this, I think, is to change people's attitudes towards prevention and vaccination being at the forefront of that for many of these diseases. Some we can predict and some we can't. So we predict, we innovate, and then I guess it's our job, the people that I represent, to produce. Those are the three things.
So what happens when there's no market case for making that vaccine? So, you know, here we're dealing yellow fever. It's a disease that's seen in low-resource countries. Ebola, if there's a vaccine made, who gets it, and is there a return on the investment? I mean, you're accountable to your shareholders.
Right. So we sit in an interesting seat. We're accountable to shareholders. We use other people's money to do our work every day, but we're also accountable to stakeholders. And so what we feel, and a part of this coalition, is that there's a joint accountability there, and we're working together with organizations like Gavi, where Pfizer's already a very strong participant in creating the incentives that will allow us to produce these vaccines at virtually no profit for us, but because it's part of our role in society. We know that you can't make a fair return on everything, but you have to be able to at least replenish the capital that you've spent. And so there are a number of mechanisms that are being discussed to give us the incentive to do that, whether they're priority review vouchers, transferable exclusivity, covering the cost of the R&D. There are a lot of things that we're working on to make sure that we are at the table, because believe me, when the epidemic starts, we get the phone calls. And so we would much rather be at the table making the phone calls to say, how can we help? And that's what we're really trying to do, to make the incentive a piece of it, but not the thing that holds us back from doing the work.
Seth?
Well, two comments. First of all, you know, why do we have an Ebola vaccine today? And the interesting thing is the industry worked at breakneck pace, but we already had vaccines in the freezer because of the bioterrorism fears at the anthrax attacks after September 11th, and one was able to dust those off and to drive forward. Plus, a lot of work had been done on these platforms. We don't have that, for example, for Zika. It's going to take a longer time, although, again, people are moving really quickly. So, as Susan said, we can begin that process ahead of time for lots of agents. We can stick them in the freezer. We can move them into testing the dose, and that would then prepare us so that we can move even more quickly. There are a series of financial incentives that have already worked. There's, we've done in the past this advanced market commitment. We did that for pneumococcal vaccines, which, were the largest killers of children in countries. Market? So the idea there is these vaccines were being made and being made available in wealthy countries at a relatively high price because of the return for shareholders. And what we wanted to do is get companies to commit to making large volumes for poor countries. So what we did is we came an agreement with them, a legally binding agreement, to have a low price, a tail price. And as part of that, we gave them, very, very long-term commitments so they could make the investments to scale up. We also gave them a top-up that they could go to their shareholders and say, okay, for a period of time here, we're getting not just the cost of the vaccine, but plus a little profit margin, but we're also getting another payment on top of that that will help pay for all of this and will incentivize to do that. Those types of incentives, we did something similar around the Ebola vaccine, are ways that the public sector can help the private sector in doing their job, which is critical because otherwise, one time they may step in and, not have to worry about this, but if we're going to need them again and again, we've got to put proper incentives in place.
And what that allowed us to do, just to follow on to what Seth said, is within literally months of introducing a vaccine here in the United States, we were able to ship it to Nicaragua, which is the first Gavi country that our vaccine was available in. And that commitment that Seth mentioned through the advanced market commitment, we've committed close to 750 million doses of our vaccine at a deeply discounted price to the 73 poorest Gavi countries in the world. As of the end of this year, we should be about a third of the way there, 250 million
I want to pull you
doses.
back in.
Yeah, no, just to follow on from that point, I think we can help the private sector by giving them more predictability. And when you think back to the yellow fever example, we asked the question when we had this large outbreak in Angola and DRC, why is the stockpile only a stockpile of 6 million doses? And the answer is actually not clear. It's because we haven't done enough work in investing on that issue and in determining what the global needs are, working with the private sector and helping them understand that actually the needs are far greater. And that could really help bring in other manufacturers, help the current manufacturers boost their own capacities, and ensure we have enough supply for the global needs.
So you're raising an issue that relates in some way to money. And Tom, I want to pull you in on this discussion and shift a little bit to talk about Zika. The president asked Congress for $1.9 billion for Zika response. Congress answered by saying, use the money that was earmarked for Ebola, and when that's up, come back and talk to us again. And it seems that the political decision-making has tended to focus on the here and now, what problem is on our plate today. That being said, when Congress gave the money for Ebola, the estimates were that there could be as many as 1 million cases of Ebola in Africa. That didn't happen. What's wrong with putting the money onto Zika?
Well, first, we hope that Congress will come through with additional dollars this week, actually, because that's what's needed. So we continue to hope that Congress will come through with the money that's needed, because we're not able to move forward on a Zika vaccine, on effective response, on supporting families who are dealing with infections in pregnant women. We're not able to develop the next generation of insecticides and mosquito control tools and evaluate what may work to control the mosquito. This is a very challenging mosquito to control, and it is really has the threat of becoming endemic in much of this hemisphere. And we don't know what will happen in Asia and Africa. We don't know what past infections may be there. This could be a global pandemic with a whole generation born with severe birth defects. We know that children with microcephaly have severe birth defects. What we don't know is for the vast majority of infants born to mothers who are infected with Zika, whether they have neurological damage. And we may not know that for months or for years. At CDC, we've already had to cut back on what we would like to do for Ebola response in Liberia, Sierra Leone, and Guinea, because we had to take that money to devote to Zika response here. This is why it's so important that we have something like a FEMA for public health, so that we don't have to go running to Congress the next time there is an epidemic. We don't know where it will come from. We don't know when it will be. We don't know what the organism will be. But we are 100% sure that there will be a next time. And rather than, at that point, run to Congress, as we did for H1N1, as we did for Ebola, and as we're doing for Zika now, and eventually we think Congress will fund it, let's establish something in advance with both the dollars and the authorities to have that kind of immediate response so you can nip it at the bud. So you can have the potential of doing the equivalent of stopping an earthquake before it occurs. And I hope that what we will see in this year is first funding of the Zika supplemental, and I'm optimistic that will happen, maybe. And second, that there's enough appreciation that there is a need for an emergency response fund in the U.S. Both houses of Congress, both sides of the aisle have had proposals for this. We have to get something in place. It may not be perfect initially, but let's start with something so that the next time there is a disaster, we can respond very robustly to it. We think with Ebola, if we had been there early on, in July of 2014, we said we needed 300 staffed beds for Ebola in West Africa. We think if those had been there within 30 days, we would have stopped the bulk of the epidemic. By November, we needed 3,000 beds. So we could probably have reduced 90% of the deaths, 90% of the social and economic burden, and 90% of the costs if we had been there on time.
Seth?
I just want to add, the other point is that Ebola is not over. So we have in the freezer the Ebola Zaire vaccine. That is there for outbreaks. That has to finish and get licensed. It has to get bought. And so when we've passed the cup around to say, okay, you know, should we put funds together to buy Ebola vaccine? People say, Ebola, well, that's yesterday's disease. The other thing is this Ebola Zaire is one strain. There are other strains of Ebola. There's other hemorrhagic fevers like Marburg. And so what we'd really want is a second-generation vaccine that covered the broader strains, and we'd want a vaccine that had the target product profile to be used for health workers or first line that you would give them. So the beginning of an epidemic was not when a health worker taking care of a kid, he thinks he has malaria, dies, and then the health worker taking care of that health worker dies. That's our index today. We shouldn't have that if we now have vaccines. But we're going to need to have that vaccine development incentivized because it's not going to be a very profitable one. So what we also need to have, and I agree totally with what Tom said, is a sense that this is a global problem. It could have spread again, it could happen again, and therefore we need the incentives in place to do it.
Peter, the United States has a strategic national stockpile that contains billions of dollars worth of vaccines, medications, other response material. Should the WHO have something similar for the globe that contains Ebola vaccine and yellow fever vaccine and vaccines for diseases that theoretically could cause problems but haven't yet?
Yes and no. So there are some stockpiles already available. One with support of Gavi we have on yellow fever, on meningitis, on cholera vaccine. And that's being put to good use all around the world, although as I said earlier, with the support of Gavi now, we're looking at how to make that a more strategic tool to be able to respond to those three diseases and perhaps in the future more. So a mechanism like that of critical partners, I think, is extremely useful. And when we involve private sector in that, then we can be much better placed to respond quickly. I think the other element is to expand the number of diseases here. And there's work going on under CEPI that Susan referenced earlier to look at those priority lists of 10 or 11 diseases and make sure the full range of medical countermeasures are there in place for that disease. So yes, more preparedness, not necessarily huge global stockpiles, but definitely more preparedness is in order.
And can I just say that, you know, for people who don't know in the audience, Gavi is, yes, it's a secretariat and organization, but it's an alliance. So it is WHO and UNICEF and the World Bank, but it's also, you know, research-based pharmaceutical companies, developing country vaccine manufacturers, and the idea and the CDC, and, you know, the idea is to have a consortium that is able to create these types of stockpiles and make them available when they're necessary.
I would just emphasize that preparedness isn't just about stuff. It's largely about people and systems, so that you know what's happening and you have people who can respond. By the time the Ebola epidemic was advanced in West Africa, a whole consortium of individuals, a whole group of people had begun working together who knew how to do an outbreak investigation, knew how to do control, and now, because we know that Ebola can persist in seamen for up to 2 years, when there was a cluster in March of 2016, it was the Ghanaian authorities, the Liberian authorities, who were able to do the bulk of the response themselves. And that kind of capacity is at least as important as the product that we need.
And that was, if I can just follow, that was really the slide that Tom showed that was so important on the joint external evaluations, because that's our objective measure now globally, to look at all those public health core capacities and say, are they in place or not? And if they're not, then how do we help countries develop those core capacities so their systems overall are much better prepared?
Well, basically everything that you're talking about requires money, resources, and to get those resources, you really need the public support for that. ABC News has done a couple polls around Zika and has found only 30% of Americans care at all about Zika. I've done reporting on from the streets of Miami in the neighborhood where Zika has been shown to transmit, and people could care less. In Puerto Rico, where there's been discussions about doing spraying, communities are up in arms, even while pregnant women, by the dozens are getting infected by Zika. Why is there this disconnect between public health feeling this is a major public health problem and the public not caring about this?
I'm not sure, but I'll give you some thoughts. In Ebola, people had a movie that they remembered. They had horrific scenes from West Africa that they were seeing, and it's contagious. So there was the idea that you could catch this terrible thing from someone who might look healthy. You're not going to catch microcephaly from an infant with microcephaly. And I think that's part of the reason we don't have that same visceral response. There's also the future. An infection today is going to result in a microcephalic infant in 6 or 7 months, because it's probably the first or late first, early second trimester where the risk is greatest. And maybe a neurological problem that won't become apparent for years to come. So it's theoretical to people, and it's not contagious in the same way. But for us in public health, it's just a terrible tragedy. Never before has there been a mosquito-borne infection that can cause birth defects. We're not aware of another mosquito-borne infection that can be spread sexually. And if you look at the definition of an emergency for the purposes of emergency supplemental funding in the US, it has to meet 3 characteristics. It has to be unanticipated. Zika is not just unanticipated, it's absolutely unprecedented. It has to be potentially catastrophic, and brain damage is totally catastrophic, and it has to be permanent.
I just would add, from the work that we do around the world, it's very interesting to move from an environment where you're convincing people to get a routine vaccination, which is often the Western world, this country, pockets of both the East and the West Coast, as well as other parts of the U.S. And then you travel to places like Malawi, where people literally do walk 10 kilometers and wait 3 hours, because today is vaccination day. And when you talk to the women who are bringing their babies, why are you here? Because I lost a child last week to diarrhea or to pneumonia, and I know there's a vaccine. Now, vaccines are not a magic wand. I wish they were. But it's the whole ecosystem that you set up around prevention and awareness, and I do think Tom's right. I think if you've lived through it, you'll remember it. Our chief medical officer talks about polio and having seen her uncle suffer from polio. Most of us have never seen anyone with polio in this country. I shouldn't say everyone. So I do think that part of what will bring this alive is the storytelling. And you connect the mothers in Malawi with a mother in Michigan, and the next thing you know, the mother in Michigan is thinking about making sure their child gets all their vaccination. Or we as adults, we get our flu shot. I mean, I do this in every stage setting I'm on. I bet you if I asked everybody in the room to raise their hand, if they got their flu shot, not everybody would raise their hand. So I think we have to make more of a culture of prevention, vaccination being one of many things. There's preparedness. There are many other things we can do. But I think until we embrace it as a part of our responsibility, not just to our community, but also to ourselves and our families and our friends, we're always going to be having this conversation, Richard.
Seth?
You know, I mean, the truth is that people are terrible at risk assessment. That's what we really know. And it's interesting how we value risks. And these are really big risks. And I think the problem is there's not perceived as really big risks. And yesterday there was a lovely event to celebrate the 100th anniversary of Johns Hopkins. And, you know, what they were talking about is some of the work that Tom and Mayor Bloomberg did in terms of making people aware of risks, you know, through public education, through campaigns, through legislative changes. You know, we don't have that acutely when something happens, and people just think, oh, this isn't going to, you know, bother me. And I've used the analogy before. I mean, you know, in the 50s, people were terrified of nuclear war. So we have this unbelievable, you know, nuclear strike protection capability with 3 lines of defense. We spend tens of billions of dollars keeping submarines under the seas at all times, and people kind of go along with that. But this is an evolutionary certainty, but they don't see this as a risk. But more people will die of these diseases than is likely to die in a nuclear attack. I mean, by any stretch of an epidemiologic, you know, or a risk analysis. So how do we get Congress, how do we get the general public to understand this risk as a real and existing risk and then put resources accordingly?
How do we do that?
Well, I mean, I think it's the challenge, and it's fear isn't always work. Tom talked about, you know, movies that in the past have scared people into action, but sometimes fear goes the opposite way. People just, you know, turn away. And certainly I was shocked living in Geneva when I saw that, you know, that, what do they say, this news story of the decade was Ebola in the U.S. You know, this was going to kill everybody in America. This was, you know, from my perspective, we have a pretty good public health system in America. It was not a real, you know, risk in America. Yes, there could be some cases, but, you know, the truth is that people just don't understand these perspectives. You got to be a lot more scared about a mosquito-transmitted disease that could spread widely than something that, like Ebola, that's difficult to transmit. But they don't understand that risk.
Susan, to tie to something non-epidemic, the issue of vaccine hesitancy and the understanding of risk, the data showing that fear doesn't work, education doesn't work, not much works. As someone who focuses exclusively on vaccines and getting them to the public, what approach do you think is most effective to getting people to understand those risks versus benefits? You
know, I think it comes down to, honestly, the work you do, Richard. It's stories. It's talking to people. It's putting people in front of others. You see the family in California who lost a child to measles going on television and begging other parents who she or he know, the parents know, that haven't vaccinated their children, please go vaccinate your kids. This should never have happened to us. A child should not die in the United States or really anywhere in the world, but certainly in the Western world, no child should die of a vaccine-preventable disease today. It's absurd. And I think we as a company, we aren't always on the front lines because it's difficult for us to do that, because people look at us and they say, well, you have a vested interest because they're your vaccines. And I think as part of a public health community, there are many people that speak out on behalf of the work that's been done, and so that we reduce the hesitancy and we get people to ask questions, because sometimes it isn't fear, it may be they just don't understand. How does a vaccine work? What's it actually doing to me? What happens when you put that needle in my arm? I think the more we're transparent about what's in them, what's not in them, what they do, what they don't do, I think we'll get more and more people to understand the power of prevention overall, and that vaccines, as I said, are just one tool. We do the best we can, but I actually think the stories from the families that have lost members of their family to vaccine-preventable diseases, there's nothing more powerful than that I've ever seen.
Tom?
Absolutely correct about stories. We need to do much more of that in public health. I also think at a deeper level, philosophically, we have to think about the commons, about the space that we all share. You're not vaccinating your child may affect my child. You're not ensuring that your home is free of standing water may result in my family getting a Zika infection. Similarly, we as a country not devoting resources, energy, attention to strengthening the ability of other countries to find problems may backfire on us. And a lot of what we have to do in this coming period is strengthen that commons, both nationally and globally.
It requires trust, and that's something that we do have a problem with.
Peter?
No, I was just going to underscore this issue of personal experience, because in our work in developing countries, of course, we don't find a lot of demand problems for vaccination. There's overwhelming demand in most countries. And it's partly because people have direct experience, and I think that that personal connection is absolutely critical for people really demanding services.
Well, our time for discussion went very, very quickly. So I want to thank our panelists. Tom, I know you have to run and will not be able to stay for the closeout. And I want to invite Michael Nyenhuis up to close us out.
Thank you. Let's give Tom a round of applause. Thank you so much, Tom, for being here. Just wanted to pass a couple of additional questions to all of you, and Richard, to you as well. And some of this has to do with our role as an NGO that works on this, in the field, in communities every day. I'm wondering just generally what counsel and advice you have for the NGO community, who is a partner to WHO and to the CDC and to Gavi and others, and to the pharma as well, in helping to deal with some of these issues on the ground. Maybe start with Peter and just kind of go right through.
Yeah, I mean, something we didn't discuss a lot today is the role of communities. And one of the greatest lessons learned actually from Ebola was that the trust of the communities was lost over time and maybe never existed in some parts of those three West African countries. So I think the role of civil society organizations, NGOs, in helping bridge that link between governments, big UN agencies, and communities is absolutely critical. And I think one thing we did discuss today was the role of civil society in advocacy. Advocacy for money, advocacy for priority, advocacy for political commitment. Maybe two big areas.
Yeah, and Michael, I think the NGO community is often, they are on the front lines. They're on the front lines of delivering all the needed care, whether it's vaccination or other elements of what happens in it, whether it's a crisis or just the normal health system strengthening that I think a lot of NGOs participate in. So on the one hand, I think we work very closely with NGO partners all over the world. On the other hand, talking about what Tom mentioned, it's often the NGOs that are at the front lines of that prediction. You're seeing things in remote parts of countries that could become a part of this whole cycle of predicting what might be happening, getting someone in to measure it, then we can innovate and eventually produce some sort of a measure, whether it's a vaccine or something else to help take care of it. So I see you as eyes and ears on the ground that have an international connection that often the local country may not exactly have.
So building on those thoughts, at the end, it's about building capacity that is critical. And Tom talked about beds, but the Ebola solution eventually was beds because of all the sick patients, but the original solution was finding those cases, reporting on them, and then dealing with them locally. And so, for me, it's about building that capacity. And the area I would focus on is equity. So if you look at immunization, it is the most distributed intervention. We basically, probably 98% of kids get at least one vaccine one time in their life. It does drop off, and when we look at the DPT-3, which is an indicator vaccine, right now it's at the highest level ever, 86% globally, and 81% in Gavi countries, but that means that 19% of kids aren't getting that third dose and aren't there. If we can concentrate on reaching those that are unreached now or that are incompletely vaccinated, bring them in the system, vaccines don't deliver themselves. That means there's a health worker, a supply chain, a data system, a cold chain, and then you build the system that is necessary because it is that health worker, that community that's engaged in vaccines that can be the early warner. So, let's take something practical that makes a difference and let's try to extend it to everybody because this is something we know we can do. We did it with smallpox. We're in the process of doing it with polio. We can do it with the rest of the vaccines.
Richard, a last comment on that?
Yeah, I'll speak as someone now in the media who reports on public health and just emphasize the importance of stories. And so often we're pitched data, and data does not make for a very enthralling news story, but an anecdote, an experience with a parent, with a child, can be very compelling. The catch on that is that stories can also be used for evil. The story of someone who has an adverse reaction to a vaccine can be used to undermine the entire faith in the vaccine system. And so I think there's something more fundamental that has to take place in terms of how we teach science and science literacy, because this whole issue of risk and understanding truly what risk is it's a battle I fight every day in the newsroom when there's stories coming out that really don't show much of a risk, but they're very compelling. So we all have to do a better job of, and I think invest in research to understand how you help people understand risk. I am just fascinated and scared by the public reaction to Zika. You know, as a pediatrician, I know we're going to be facing a nightmare next spring and summer when babies start to be born with problems that could have been prevented. But I don't see how to move the needle and change behavior right now. It's, that's, I think, an unanswered question.
Well, on behalf of Americares, our staff around the world, our partners in many countries that are dealing with the issues you've been talking about today, I just want to thank each of you for the work that you do to move the needle on these important topics. And thank you for being here with us. Richard, thank you for a great job moderating our panel, and let's give them all a round of applause, and thank you very much.